Okay, so we've already had the introduction of Jessica Martin, but she'll go ahead and start teaching us about the discharge educator training. And I do want to say that as you listen to this, we have looked at this facility-wide as to whatever she goes over, and I haven't seen her slides yet, but if there's something that definitely doesn't meet mental health or definitely doesn't meet some other area, the goal here is that we have everybody here so that you can see what parts of this or how could you use this in your area and make it work for you. This isn't by any means that the ARC group is going to roll out something that would not work in your area. We are going to be having more and more frontline staff working with us as we move forward. And so this is just for those of you who aren't in inpatient specialty and hospital-based services, the best one in the house. Please feel free to just gain from this and adapt how you can. Thanks.
Thank you. I also speak quietly, so if you can't hear me, certainly ask me to speak up. I didn't get Alicia's memo to wear red, but it wouldn't have mattered anyway because I have no luggage this morning. So if it weren't for Brian's daughter, I would be wearing my running sneakers right now. So, okay, so we're going to get to the nitty-gritty of the RED process. And what I'm pretty much going to do is go over the contextual, how we collect the information, what information we're collecting, and how we're going to package it. And then Dr. Mitchell is going to do the how do you actually teach it to the patients and deliver the entire RED process. So I'm going to do the collecting and the packaging. Okay. Okay. Okay, so the role of the discharge educator, we do. Oh, actually, first I wanted to say that, I understand that here in Palo Alto, it really is a nurse-driven initiative. So as far as credibility for Suzanne and I being the ones who are doing the teaching, for myself, I was the project manager for our most recent RCT, the randomized control trial. So I worked with the discharge educators every single day, and so I kind of fulfilled some sort of research assistant components of the RED discharge. So I was immersed in the entire RED process every single day. And a lot of what the research assistant's role in Project RED was helping to gather and collect this information. So I'm very familiar with this first part of the presentation. So the role of the discharge educator is to coordinate, organize, and teach the discharge plan. So they really are the overseers of the process, as Brian has said in previous presentations that I've heard him give. If no one owns the process, or if everyone owns it, no one owns it. So the discharge educator really owned the discharge process in Project RED. So she oversaw the discharge planning. So she wasn't doing the planning per se, but she was coordinating it and organizing it. And I know at a lot of hospitals, they have people who are doing the planning, the social workers, the discharge planners, the discharge coordinators. So it's the discharge educator that kind of oversees the process and brings the plan to the patient. Okay. And who are the discharge educators? It's the age-old question. One of the first conversations I've been having with a lot of the hospitals. And as you heard, in our study, we used designated research nurses. So, and we refer to them as discharge educators or discharge advocates. It can also be, as David was saying earlier, he really is bringing in multiple people on the team for the discharge planning and the education component. So It will involve case managers and the floor nurses, social workers, care coordinators, and it really is important to divide up the responsibilities so that people own specific parts of the process. Okay. So what's the after hospital care plan? And Brian went through all of these, so but again, it's the first time you're seeing it, so I'll go over them again, but I won't dwell on the same slides that you've seen. So the after hospital care plan, the AHCP, is a personalized care plan. It's used to teach the patient about his or her discharge plan. It was designed by graphic designers and health literacy experts so that it was easily understood by patients. And it contains the information needed by the patients for the days between discharge and when they're going to first see their primary care doctor. It gets printed and given to the patients. And as Brian alluded to earlier, it's very different than the discharge summary. The discharge summary is made for clinicians, and the discharge plan, as it's presented in the after hospital care plan, is for the patient, for their caregivers. Okay, so this is the cover page of our hospital care plan. It's branded for the hospital with the hospital logo. It has their discharge date, their discharge advocate, or whomever is going to be kind of covering that black box area of after discharge, before your PCP appointment. You know, that's we had our discharge educators available via phone, you know, if they to kind of cover that chasm of no care. And then also their primary care doctor. Again, these are our medication pages. We used color coordination for our color-coded pill boxes. And so the yellow in the morning, when to take it, why you're taking this, the Latin and the generic names of things, or the brand name, how many pills, and how you're supposed to take it. One of my favorite stories that I heard at a lecture was a mom brought her daughter in. English wasn't her first language, and the daughter had an earache. And the doctor gives her a liquid, and I'm not a clinician, so a liquid antibiotic, and says, you know, give this to your daughter, she'll be great. And mom goes home and puts the liquid in the child's ear because that's where it hurt, you know, and it was meant obviously for the child to drink. So even though it seems sometimes people with higher health literacy will say, well, that's ridiculous. Why are you telling me to take this by mouth? But that's why. Okay, and then again, a different color for noontime, coordinating with our color-coded pill boxes that we gave people. And then at the end, the white zone was all their PRN medications. Okay, this page, I know you've seen it, so it's the appointments page. Your main medical problem, your discharge diagnosis, your date of appointment, who the doctor is, where it is, which Suzanne will actually tell a story later of where it is so important, and the reason you're going for this appointment, and the phone numbers, and then again the color coordinated calendar page. So this is what we call our patient activation page. Again, at the top, it's the questions for your primary care doctor, and we really have to encourage people to write in the booklet. Unfortunately, with all my clothes are the after hospital care plans, so it's somewhere in San Jose right now, and it's, you know, it's packaged nicely. It looks it's bound at the top, so, you know, encouraging patients to actually write on this page, you know, and write with them, because they sometimes were resistant to messing it up. So this is, you're going to ask these questions of Dr. Jack when you go to see him. And also at the bottom, what Brian was talking about earlier is these are the tests you had outstanding when you left the hospital. Because oftentimes you don't know what tests you had while you were in the hospital or what results came in and didn't come in. So it's automatically on the after hospital care plan that, the test was done on this day. They expect the results here, and it's Dr. Jack who's going to be the one who's going to follow it up. And we saw this one before. And just the simple things of what you should be looking out for, and the simple action items of things you should be doing when you go home. And then the all-important map of a campus. Our campus is really large. This is actually the BMC campus, which is ever-changing, and it's an old campus, so you're on floor 3 in one building, and then you walk across the hall and you're on the 4th floor. So very important to have the map. And additional elements of the after-hospital care plan that can be automatically generated in the HCP through the software system is a list of the patient's medication allergies. Often they're not listed anywhere for the patient, or they don't have a collection of all of their allergies in one place. A list of the durable medical equipment that they're going home with or that will be delivered. Also on the cover can also be the patient's advance directives for end-of-life care, and those are options, again, in the software system. And recommendations for diet modifications and exercise regimens that can be kind of standard language. And Marcus, who is from Engineered Care, the software people, will go over the options, but so there can be kind of standard language, try to walk 20 minutes a day, or it can be very specific and you can type things in to have printed out for them. Oops. So the workbook versus the workstation. So the workbook is used to communicate between the discharge educator and other team members. So if there's job sharing, if there's case managers, anyone who is going to be collecting the information to be taught to the patients, they'll use the same workbook. And it really is the discharge educator's checklist of the information that needs to be collected. The information in the workbook then correlates with tabs found in the workstation, so it allows for easy entering. So the workstation is the software program that creates the after-hospital care plan. The workstation automatically prints the formulated AHCP. It currently prints in English, Spanish, and Chinese, Mandarin Chinese. Some of the information imported into the workstation, it can come directly from the EMR, as Brian was saying earlier, which is obviously much more efficient and eliminates potential copying errors when you're doing the medication lists. And these are workbook excerpts. And the workbook can be found in the tool, like I think it's called How to Deliver Red at Your Hospital. There's a bunch of appendices in that tool, and the workbook is one of those appendices. So the workbook contains 9 sections, and the first one is diagnoses. What is the admitting diagnosis and the discharge diagnoses and any comorbidities? And this will kind of inform what types of teaching need to happen for the patient. Follow-up appointments. Does the participant, the subject participant, it's all written in randomized control trial language. So when you see subject, it really is your patient. So does the patient have a primary care physician? Preferences such as gender and language and location, and the all-important day of the week, time of day, so that they can actually attend these appointments. So we all know the importance of the follow-up care, so we want to make sure that we make an appointment that works for the patients. And we'll talk more about that in a little bit. Other sections of the workbook include the appointment details, what you've actually made for the patient. And again, it is a communication tool between the discharge educators. And whether or not transportation was discussed with the patient. Do they have transportation, and was a plan made? This is a snapshot of the workstation. This is the home page. Again, there'll be an entire presentation about this later on today, but this is where you'll be entering in all of the information from the workbook. Okay, so using the workbook in the workstation, and now how this information is tracked and packaged. So we're going to start preparing how to deliver the REB. So we always like to obtain information from several different places because we know it varies a lot. So from medical records, from the patient, from the family, from an outpatient source such as the primary care doctor or their outpatient pharmacy. And these are the bits of information that we're going to collect about the patient before meeting them. Demographics, language preference so that you know whether or not you're going to need an interpreter, more demographics, their diagnosis, the medication list, and usually this is the most variable. So again, using inpatient, outpatient, patient report, pharmacies. Brian alluded that currently at Boston Medical Center, they are the health plan, the BMC HealthNet plan, which is the managed Medicare plan, is doing Project Red. So they actually have access to what the patients have actually filled at the pharmacy as opposed to what they've been prescribed. And it's often very different. So it's a nice double check system that they have available to them. Again, we're going to collect their medication, allergies, any sensory deficits, equipment they already have at home or that they are going to need at home, their scheduled tests, anything that's not going to be done by the time they leave, and their advance directive or healthcare proxy. So next, we need to talk with the in-hospital care team. The communication from senior leadership is really important here in that so that everyone knows who the Project Red people are, that they're going to be coming to the inpatient team to ask them this information. And communication, always key. The best way to communicate with the team, at our hospital we do a lot of text paging back and forth. Confirm the diagnosis. Also confirm the medication list for discharge. Again, as we know, that's going to be quite variable. What's the expected date of discharge? Any concerns about discharge, whether or not maybe the patient doesn't know the diagnosis, so can we speak directly to the patient about diagnosis? Does there need to be a family member in the room pretty much every time we talk to the patient? Just, so no one's reinventing the wheel here. Information about the diagnosis comes from, again, the chart and the team, specifically to identify the comorbidities. There's often information not yet captured in the medical record, like a comorbid condition, that could be very helpful in preparing the patient for discharge. Often patients will be readmitted not for their index hospitalization diagnosis, but for a comorbid condition. And as policy shows, it doesn't matter why they come back in 30 days. It just matters that they come back. So even if they're not there for their diabetes diagnosis, maybe that's something that the discharge educator should do some teaching on, because they're not managing their diabetes really well, which is leading to other health problems. Okay. Always important to orient the patient to the REV program, just understanding what you're there to do for them, and I guess just making sure that they understand that you're going to be making appointments for them, but appointments that they're going to be able to keep, that you're going to be coordinating their discharge plan and meeting with them daily, as we talked about before, that you'll meet with them daily to inform them about changes in their discharge plan, and also to discuss any updates with their medical condition, anything that the team would like to be. I often hear the discharge educator saying, is there anything you would like me to talk to the patient about today? There's a million things that you might want to say to the patient, but the inpatient team's not going to, may not have that time, or the floor nurse may not have that time. And that you're going to be responsible for teaching them about their medications before they go. So for the first meeting with the patient, tools to be able to increase understanding and retention. Again, assessing for language assistant needs, even if the patient says, I'm fine, I understand you, whether or not you're comfortable and need to have a trained medical interpreter in the room. Speaking slowly, using plain non-medical language. Active listening. We had a presentation at Grand Rounds last week, and there was the acronym that the doctor came up with. It's called STILL. And coming in the room and sitting down. So important not to feel like for the patient not to feel like you've got your foot out the door already. And it's something that we do, especially for research, because we're trying to get people to participate with us, and with being research assistants, going in and sitting down in the room, you might not leave for another hour because you're the first person to have sat down with that person that day, So take the time and sit. The T is for time, understanding that hopefully you will have more time than the other people they're interacting with on a daily basis. The I is for inform. So informing the patient of the plan as opposed to prescribing it to them. So, how does that sound to you? And this is what they're talking about, and engaging them in this process. And active listening, as we set up there, it's just really huge to building rapport with patients. Building rapport. So these are things, especially I'm sure the floor nurses in the room know these are things that you do on a daily basis, but it's really just taking the time to, so that you can ensure you're giving the best discharge. You really do need to be able to engage the patient in your process with you. Okay. So from the patient themselves, we will collect and again put into the workbook what's their PCP name and where they're located. What's the patient's understanding of their illness and treatment? It can give you an idea of teaching needs or any cultural considerations, which Suzanne will touch on much more. But why does the patient think they're here? It's a really good place to start. Medicines that they were taking at home prior to admission, because again, that will potentially vary greatly from what their inpatient medication list looks like. We really try to get the family involved. So who's gonna be helping out once the patient goes home? You know, what does their social support system look like? Any and all pharmacy names, their medication allergies, their advanced directives, and again, the durable medical equipment that they have at home. And then in the daily interactions with the patients, again, the length of stay will vary greatly from, you may have one chance meeting with the patient up to 5-7 days. So you really do need to prioritize what you're going to cover during your sessions with patients. So goal of the follow-up patient sessions is to teach the treatment plan and identify the discrepancies between the clinical team's discharge plan and the patient's understanding. And again, this goes greatly into the teach back that Suzanne will talk about. Encourage patients to identify someone who can support them during their transition so that that person can be included in the conversations. As Brian was saying, the cognitive ability of someone in the hospital is not very stellar. So just having another set of ears, someone who also is going to be there when they leave, it's important to include that person in the in-hospital conversations. And again, due to the short stage, you're not going to always have time or the opportunity to teach and reinforce all of the identified elements. And so the post-discharge phone call can be used to reinforce these, but it is important to communicate what was taught in the hospital. And again, this will be done in the workbook, the discharge educator workbook, so that the person conducting the post-discharge phone call will know what elements are remaining that really need to be reinforced. Okay, so we know what information we have to gather. We're recording it in the workbook. We're going to enter it into the workstation, and Suzanne is going to go over the specific components, our red checklist.
Great. Good morning. It's great to be here. I used to live in Los Angeles. I lived down there for 10 years, and so I'm so happy to be back in California and to be here to talk to you about Project Red. I worked with the discharge advocates a lot on their scripts when we were adapting Project Red to the Louise technology advocate. And so I'm very familiar with the kind of conversations that the discharge educators would use with the patients as they taught them the discharge plan. And I think that the other thing that I would keep in mind as you craft ways to implement Project Red in your place is to think about this as, that the discharge educator role could, possibly be conceived in a team environment, so that it's possible to conceive the delivery of this role in a team approach if your team is a high performing team. So we'll go through some of the steps on how to prepare the information and deliver the discharge plan to the patient. So this plan comes from 11 mutually reinforcing components that we've visited already this morning, but we'll go over them again. The first component, and one of the things that the discharge educator will do in preparing the patient for discharge, is to help the patient make appointments for follow-up medical appointments and post-discharge tests and labs. And this is really important because in the past, even when we made appointments for patients, we would just say, here's your appointment for Tuesday at 9. Hope you make it, and most of the times that was impossible for a patient to make, not just because they may not have, transportation or support to get there, but it's just simply not a convenient time for them. So as the discharge educator, one of the most important things is to ask them before the appointment is made, when can you go? What's the best time? I mean, if you made an appointment to have your hair done, that would be the first thing they would ask you, right? Or any other appointment would be, when can you come? And how are you, and how will you get there? Because a lot of times, the patient might, and this is where family engagement might be important, because the patient might say, oh yeah, I can be there at 10 o'clock on Tuesday. But then the daughter comes in and says, no, Mom, I can't take you then. And then you realize that you have to, redo the appointment. So finding out when the patient can be there and how they intend to get there, and any possible barriers. So even when they give you a time and when they give you a strategy for getting there, asking them if there's any reason why that time might not work. And then also letting them know that if that time needs to be changed, how they can go about doing that. Because I don't think even in highly functioning, health literate people, you can't give them too much detail when they're leaving the hospital. And, I've seen all ranges of patients, and because the hospital experience can be so difficult, people can walk out totally themselves, not themselves, and not be capable of managing things that they would in their normal everyday life. So I don't think it's ever, you can never overdo it or oversimplify the conversation about, when can you make this follow-up appointment? Because we've already seen earlier this morning how important that follow-up appointment can really be to keeping patients safe. Planning for the follow-up of results from lab tests or studies that are pending. Of course, this is a huge issue, and if you have ever worked in the outpatient setting, it's really a moving target, because if you don't know a test was done, how do you know to follow up on it? And then I remember having a guy call me up a month after an x-ray was done on his arm and say, I never got the results of that x-ray in the ED, and I looked it up and it was a fracture. I mean, these are the, this is the obvious. And I don't think much of this is really rocket science, but it has to obviously be explicit, because otherwise we don't do it. And again, the identifying specific roles and responsibilities, because unless it's somebody's responsibility, it's nobody's responsibility. And I've heard this time frame between the discharge and the follow-up as the no-care zone. Patients experience the no-care zone. And I've had lots of experiences, with patients having these problems. So planning for the follow-up of results from labs and pending tests, that's a good place to put that information in the after-hospital care plan. And when you do your teach-back, make sure the patient knows that that information is in there and that they should be following up on those results. To organize post-discharge outpatient services and medical equipment. So the medical equipment piece can be huge, as we all know, right? I mean, the person who gets home and they don't have their nebulizer or their oxygen, like everybody's nodding their head, because it's such a common experience. It seems like it's, a no-brainer when you're doing your discharge and you're passing that on to somebody else. But when you see that person back in the ED or back admitted because they didn't get what they needed on the outpatient side, it makes you feel discouraged, because it was an easy solution if the patient had just been able to get what they needed. So really having somebody who's responsible for making sure that those services are implemented in a timely fashion is really helpful. Identify the correct medicines and a plan for the patient to obtain and take them. So we can't say enough, right, about med reconciliation. There's tons of literature about the problems with med rec. I still go home with a little PTSD occasionally trying to do med recs, because these are one of the, really high, these are landmines, med recs, because even at the best, even at the best possible intentions, there's almost always an error. And so trying to use multiple sources of information, the family, the patient, medicine bottles, and the outpatient list if it's available to you in an EMR, Or if sometimes patients are good about having lists of their medications, using that to figure out the medication reconciliation, and then to teach that to the patient about their medications, and then ask them about their plan to get the medicine. Because, I mean, you can tell there are patients that go 5 or 6 days. They say, oh, I just couldn't get there. Or, oh, they didn't carry that, and so they were going to contact my doctor. And, we find those things out in the 3-day follow-up call. Oh, that wasn't covered by my insurance, so they were trying to get a hold of my doctor. And then, they can never get a hold of a doctor. I discharged a patient from the hospital. I was on the inpatient service. It was a Saturday. We did all we were supposed to do. I did my discharge summary. We sent it to the PCP office. And yet, on Sunday, the VNA called me, had me paged, and luckily I was still on duty. And she said, the patient can't tolerate this antibiotic, and the PCP office won't do anything about it. They basically said, we didn't prescribe it for you. We don't know what happened to you in the hospital. We can't go to the ER. So instead of sending her to the ER, she tried, the nurse, the VNA, paged me at the hospital, and it was lucky that I was there to take the call and change the prescription. But even under the, we're the choir, even under the best possible circumstances, we can still run into barriers. So, having a plan, telling the patient, what are you going to do if something happens with this plan, is really important, because sometimes that's all they're going to remember is, what can I do if I run into a problem? And finding out what their plan is for picking up the medicine. And sometimes it's helpful, if it's available, to figure out ways that they can have delivery, if the medications can be delivered to their homes. That might help for some patients who have transportation issues. Okay, reconciling the discharge plan with national guidelines. There's nothing like evidence-based medicine, right? I mean, it's not easy to practice evidence-based medicine. It's makes sense, but sometimes when you're face to face with the patient, or you're in the reality of a really busy inpatient setting, getting a lot of patients discharged and admitted, paying attention to evidence-based national guidelines can be overwhelming. And so having as many eyes on the discharge plan as possible is helpful. And if you encounter problems with your clinical teams, when you come up to them and say, I noticed this patient, then that should be addressed at the highest level, I feel. Because you can't be a high-performing team unless everybody is respected and allowed to put their input in. Yes?
How do you operationalize that aspect? Do you have some tool for all for the coordinator?
Sorry, but to teach the plan that's already been, okay. So not so much to make the plan, but to teach the plan. And so then, if there are issues in that checklist, then they go back to the team that's making the plan and discuss them. Sometimes there are real reasons why those things haven't been done, or they've been done, we just didn't know it. Lots of times there's not. It's just a good opportunity for double checks at that time.
And like I said, sometimes the discharge advocate or the educator will come up with some cross-disciplinary tensions, or they don't feel that their feedback is welcomed. And I think that's got to be addressed at the highest level. A high-performing team allows for that. And you should be able to go to the team and say, this is a CHF patient, and I notice there's no ACE inhibitor here. Did you intend that or not? And I think that you should welcome that coverage. Cover your back, your blind side, right? As clinicians, clinical teams should welcome that extra pair of eyes, and that in that way, the discharge educator should be part of the team. They should be on the team. They should be considered part of the team. Teach a written discharge plan that the patient can understand. So, this is what the after hospital care plan is all about. And, it's colorful, it's appealing, it's got symbols, it's designed to be easy to digest, and it's user friendly. There's places to make notes, and it's at the airport. I'm sure they'll be here at some time for you to see as a demonstration. But I think that, for patients, it's something that looks very friendly and familiar, and you can sit down and flip through it, as opposed to a lot of language that seems scary and intimidating and, makes you worry about yourself. And so using the after hospital care plan to help teach the patient about what they need to do to keep themselves well at the time of discharge, I think is welcomed, and the after hospital care plan is an easy tool to teach too. So if you refer to it, the patient knows where the information is. They can recognize what information is in there, and then that will incentivize them to refer to it when they go home, we hope. Patients did like it a lot in the Project Red research outcomes. The patients definitely liked the after hospital care plan. Educate the patient about his or her diagnosis. As we saw earlier, so many patients don't even know why they're in the hospital, and that's not uncommon. I mean, I don't think that's uncommon in a lot of places. Even, people who can be very involved or have family members who are very involved may themselves not really understand. And this is important as a discharge educator or any clinician that's on the team to make sure that everybody is aware of what the patient knows. So when you check in with the clinical team, I would do that every time before you talk to the patient, because, the one time I had someone go in and tell a patient, you have cancer, when we didn't even have the pathology back. And so, you don't want those kind of miscommunications to happen. And so, making sure that the patient is aware of their diagnosis and that everybody that's communicating with the patient is giving the patient the same information. And then once they have a diagnosis, because sometimes as the admission evolves, right, the diagnosis is being figured out, and sometimes you're talking about symptoms and possibilities. And using the teach-back method that we'll talk about in more detail to make sure that the patient is gaining understanding of your time with them and your education. Assess the degree of the patient's understanding of the plan. So here we are at teach-back. How many here use teach-back or are familiar with teach-back? It's pretty well known these days, and it's, again, I wouldn't call it rocket science. It's really just checks and balances. And I first became familiar with teach-back when I began my work in patient-doctor communication, and we were talking about teach-back in cross-cultural settings, mostly because we wanted to know, are we on the same page? Are we on the same page? And what I've found is that even in what aren't considered cross-cultural settings, a lot of times the patient is not on the same page as us in their understanding of what's happened to them or what they need to do when they go home. So there's, kind of a medical culture and a patient culture clash that can be easily addressed with the teach-back method. Review with the patient what to do if a problem arises. And this is when patients just throw their hands up and call 911, is because they feel so overwhelmed and so alone that they don't know what to do when even a small problem arises sometimes. So, one of their biggest complaints, as we mentioned earlier, is that they feel alone. Or when they've tried to call for help, they either get no answer, no call back, or they're told to seek care elsewhere. And they're kind of sent on a little circus race. And so knowing what to do if something's going wrong, knowing when there's a problem that you need to act on and when there's something that can wait is really valuable information. And because, I think of this in terms of the airline again. We've talked about airline checklists, and in my mind, I think if I only knew what turbulence wasn't scary and what turbulence was scary, I might be more calm on an airplane. I think it's the same thing with patients at home. If they knew their symptoms were worrisome and needed to be addressed, they would know to get care versus something that could wait. And I think that's, that would help improve relationships between, with the outpatient settings as well. So teaching them what they need to do, who they can contact, where they can get care when they have a problem is so important, especially for patients who are being discharged on weekends. I think it's very important. Expedite transmission of the discharge summary to clinicians accepting care. I don't know how much you interact with discharge summaries, but for me, it's a big deal. I work in SNFs, and I can tell you that this is some of the worst reading sometimes. And when I get a good one, I feel so happy because I know what to do. I know what's going on. I know what happened. Some of them have ... still on the end, like, and then what? Like a bad, fairy tale. And this is, I can't say enough about timeliness. It's not good to get a bad discharge summary in 24 hours, but at least the patient was in the hospital, and there's usually some doctor's name on that you can hopefully track down. So, the discharge summary issue, I just can't say enough about it. And it's kind of appalling to me as a clinician on the inpatient and the outpatient side that doctors don't pick up the phone and call an accepting physician. Because if I want to send a patient from my SNF to the emergency room, I have to call, and with what we call an accept in my system. And I have to, tell the accepting physician what's going on. If I take a patient from the ED onto the floor, the ED physician has to call me and say, here's what's coming up. Do you accept? But, when I discharge a patient from the hospital to home, I don't have to call anybody. I don't have to tell anybody, or transfer the care of that patient officially to another clinician. And I think that that's hopefully, going to change, and I hope that, the changes in the healthcare system will bring about positive change in that gap of communication between professionals. We have to stop ignoring each other. What's wrong with us? I feel like we need to talk, what's wrong with that? It's okay. Provide telephone reinforcement of the discharge. This, I think everybody agrees this is a powerful time. And as Dr. Jack said earlier, it's not a social call, but the patients still feel good, like somebody's checking on them, as if it was a social call, but we get down to business quickly. But, getting somebody to, getting a phone call after you get home makes people feel like, oh, somebody still remembers me. I can remember being called at home once after an ER visit and feeling very, having a really positive emotional response to that. Wow, that nurse remembered me and bothered to call. And I think, we recognize all the bad things that happen in the first 72 hours when we make that call, particularly around medication and adverse events, and hopefully can intervene with them in some way. So arranging for post-discharge appointments, I've talked a lot about already. We can go through these one at a time, and if you have questions about how we do it, please just raise your hand. We'll just chat about this. I've already talked a little bit about this already. Making appointments for follow-up, what does that sound like? Basically, you schedule, typically for us, it's arranging for a PCP appointment within 2 weeks. And then if they don't have an identified PCP, we go ahead and identify one for them, and we put it in the after hospital care plan, hopefully with a photo of the person that they're going to be seeing. We arrange appointments with consultants as well. We identify whatever follow-up tests. So sometimes patients come in, they're not that acute, so they have an outpatient colonoscopy scheduled or an outpatient stress test scheduled. And those things have to be scheduled, and the location of those tests need to be made known to the patient. This is a lot of information to go home with when, especially if you've had a particularly difficult hospital course. We arrange for visiting nurse. We find out when they're going to come. And again, home oxygen delivery and other types of medical equipment, if they have beds showing up, medical beds, things like that. And it's just not worth making an appointment unless you ask them when they can make it and how they're going to get there. So, any questions about that? Yeah. Again, so they'll get the discharge summary, and they will get the discharge summary if we send it to them. So 91% of our Project Red patients, the discharge summary is delivered to the PCP within 24 hours. So they may not know who that is. They may say, "Oh, here's a discharge summary on Mary Alice Jones. I don't know who that is." But in the discharge summary will be the date and time of the appointment. Now, if they don't have a relationship with that PCP, that's obviously a risk that they may not show up for that appointment. But nonetheless, I think, we were able to show in our project that more patients who had an appointment and had the appointment made for them showed up for that appointment than usual care. So, any other question? Yeah.
How did you pick 2 weeks? In my experience, patients either flounder within the first week or they're ceiling at that point. We've been trying to get them within a week if they feel like they need an appointment. And I was talking to Dr. Sinsky. She's at Dubuque, Iowa.
Oh, yeah, I was on a panel with her once.
Yeah. And she was at something earlier in the week, and she sees all theirs regardless within a week. So how did you come up with the 2 weeks?
I don't think it was rocket science. I think, the literature says, 2 to 4 weeks, but I don't think there's been any identified ideal time for follow-up. I think pretty much everybody agrees that the sooner the better. But because of capacity, I think that 2 weeks is reasonable, and it's halfway before the 30-day mark. See, it's not rocket science. It's not rocket science.
Hi. When you make a referral to the VNA, do you communicate with them as far as follow-up teachings, who to call for lab results?
I think they coordinate it, but they don't really coordinate what the VNA should do. There are orders to the VNA, and they coordinate that the VNA will come, and they teach that to the patient. The patient will know that the VNA is going to show up tomorrow morning at 11 o'clock, the VNA service, and the phone number in case the nurse doesn't come. But there really isn't, again, that's another communication gap where, there's not really care planning between the discharge educator and the VNA service. Yeah.
Typically, how long are your post-discharge telephone calls?
Okay, so from our research perspective, which isn't necessarily a real life perspective, she would spend anywhere from up to 30 minutes, right? Some were quick, depending on the patient's needs, and some were long. And she could spend an additional 10 to 12 minutes or even longer doing care coordination interventions. So trying to contact the PCP if the prescription didn't get filled because it needed to be changed because of formulary, or if they found the different types of errors, patient adherence errors versus system errors that she would have to take action on. So sometimes it was just a matter of going through the medication list, and sometimes it was a lot more complicated.
We do have to use the microphone when we ask questions because it's being taped. So the next person that speaks without the microphone doesn't get potato chips with their sandwich for lunch.
And because I'm wearing this antenna, I get your potato chips. I feel like a bug, not a rock star. It feels more like an antenna to me.
Okay, I have a microphone. I get potato chips. A question is your transition to a nursing home. How would you communicate with them?
But actually, most of our patients were discharged to home. So patients who came in from SNF were not eligible for the Project Red intervention. In our research, doesn't mean that they wouldn't benefit. But in general, ours was a hospital to home intervention. Yeah. But as a SNF provider, I wish anybody would communicate with me. Anybody at all. I mean, anybody at all. It's a scary place, the SNF, if you haven't been in one recently. Okay, so see, you're all laughing because you know. Alex is a case, and I'll just read it to you because I don't imagine anybody, even with good vision, could read this. So he's a 54-year-old guy who was admitted to the hospital after a week of intermittent chest pain. He works full-time, has a wife and 4 kids. He has no past medical history documented. He's a smoker, and he says he's under a lot of financial stress. He doesn't have a PCP, but he's willing to be assigned one. And we'll have a follow-up appointment if it could be after his normal working hours. So here's another male-associated issue is access, right? A lot of men won't come to regular work office hour times. So he needs a follow-up appointment after his regular working hours. He's ruled out for MI, and the decision is made to discharge him after 2 days. He has no more chest pain. Given his age, his smoking history, and he's got high cholesterol, which is newly diagnosed, a stress test appointment was made. Unfortunately, he would have to take a day off of work to make it to the stress test. But he agreed and was discharged with a new prescription for statin. He was assigned a new PCP and given an evening appointment for that clinic appointment near his home, and he got an appointment for a stress test that was unfortunately late morning on a Tuesday. He was given instructions to come back or call 911 if he got recurrent chest pain. He took the day off to go to his stress test. He went to the clinic near his house instead of to the stress test clinic. This was the wrong location, and he quickly drove to the hospital where they told him it was too late. So he didn't get his stress test. He lost a day's work. He next presented with chest pain in the ED, probably just from, that interaction at the stress test clinic. They probably said, oh, call 911. Call 911. But this is an example of how systems fail patients. And, and it's not unreasonable to think how we could, with being proactive and coordinating care, avoid these kind of problems. Patients make choices every day, all the time. They make decisions for themselves about medication, about what they need, about what's more important. And sometimes it's more important to go to work than go fill your prescription. It's too much of a hardship to miss a day of work and worry that you're going to be the next one laid off. We all know that, right? We all know that about our patients. So whatever we can do to avoid these kinds of things that reinforce not seeking care in the best venues is going to help not just improve patient care and reduce readmissions, but the experience of healthcare for patients. Yeah. Okay. So what if the patient doesn't have a PCP? I don't know. How do you deal with PCPs? Do you have communication with PCPs? Do you have on-site primary care?
Are you asking how we treat them?
Or just, if you treat them well, I might be in the job market.
So if we have a patient that is in hospital and doesn't have a PC assigned, what we'll do is assign them to a PC in their location for their demographic area, okay, so that they leave with a new primary care provider.
Okay. And do you have any idea how well that works?
Just say very well.
Works out great every time.
So that would be good information to know. Like if you do hook someone up with a primary care doctor that they've never met before, is that working? Is it helping them get outpatient care more effectively and access care before readmission?
That is actually something we're looking at of the appointments that we make post-discharge, how many of them actually make those appointments. We don't have that data yet, but we've requested it.
Yeah, so I think that's good, because if they're not making it to the appointments, that's probably resources that would be better spent in some other strategy. So we learned how new PCPs are assigned at our hospital, and the PCP may have been assigned without the patient's knowledge. So you may look up their insurance and say, "Oh, you're assigned to Dr. Mitchell." And the patient's like, "Oh, I don't know who Dr. Mitchell is." And sometimes there's a lot of gyrations you have to go through to change a PCP. But in general, we haven't found that to be a problem. It's good to ask the patient if you're dealing with them on the inpatient setting and you're assigning it. Patients do have preferences for gender, location, especially if it's primary care, the payment source, and language. If you have people who prefer to communicate in a language that's not English, those language services, having a language concordant provider can be critical to them hooking up with the right person. Following up on labs and studies pending at discharge. So, one of the most important things I think the discharge educator could do is pull this information together in one place. Because so much happens in an inpatient setting, especially if there's multiple specialists on the case, that it can be hard even for the primary team to keep track of what's outstanding. I mean, I've had patients go off to different specialty services, evaluations during their hospitalization, and not find out because of the documentation may not be timely, that the patient had a procedure done. And then I find out from the patient, that they did something to me. They put me to sleep and did that, cut that thing off me. And, you don't have any idea what it was. So as a discharge educator, that's one of the most valuable things. And again, I'm thinking about teams, having another set of eyes, another brain, another person's energy on those critical pieces of information is so important, because care can be so fragmented during a hospitalization. Things can be outstanding and you're not even aware of it. So obtaining a list and collating that list and putting that into the after hospital care plan can really solve a world of problems. And then explaining to the patient that some of the tests are still not ready. So sometimes the patient leaves the hospital, they don't even know that the results aren't back for their tests. They just know no one's told them anything about it. And so they're not aware that there's something outstanding. As my patient who had a fracture, he just assumed that his x-ray was okay because no one had called him. So it's really important. That's another good thing about the after hospital care plan. It will list whatever's outstanding for the patient, so they'll know to ask about it. Organizing post-discharge outpatient services and medical equipment. We've already talked about this, including V&A. Identify the need by reviewing medical records and speaking with the clinical team. So, organizing all of this additional care that the patient might be needing. A part of this is a care coordination function. So you might collaborate with case managers that are also helping to organize some of these services. So med reconciliation. Yeah, I know. I saw you roll your eyes. That's how I feel. I feel a little sick in my stomach. So the purpose of a med rec is to determine that the patient's discharge medications list reflects the most recent and accurate update. And, I can't say, these are just, you should always look at a medication list with skepticism. because that's the safest thing to do. That's universal precaution. Most likely there's something on that list that's a problem, that's wrong, that's not being used, that's an interaction, that's the reason why the patient's in the hospital. You know, I just feel that that's probably one of the best places to begin. But as a discharge educator, hopefully you have a day or two to try to pull that information together to the best of your ability. If you have access to an outpatient EMR, that's a good place to begin. But again, I would caution you to be not too reliant that that's an accurate list. And if you have the chance to go over that list with a clinician that might be current with the patient or with the patient themselves, they might tell you, oh, he gave me that, but I never took it because I didn't really need it, you know, or I didn't have symptoms anymore, so I stopped it. Or it was too expensive. Patients do that all the time. It was too expensive, so I just took half, or I just stopped. And so taking that list and going through it with the patient, one medication at a time. If you have an inpatient pharmacy that, you know, the patient uses regularly, that's a good way to do a check, a cross balance with, is the patient actually filling the prescriptions that are in the outpatient record? So you can see med reconciliation can be consuming, but it's also one of the number one reasons for an adverse event after discharge, our medication events. So it's worth spending the time to make sure it's as accurate as it can possibly be. Review the list when you first meet the patient. So one of the first things you might want to do after you've introduced yourself, after or however you decide to deliver this intervention, but whoever's doing the med rec, to let the patient know what you're trying to accomplish. Make sure they're well enough to interact with you, because sometimes, you know, everybody has their story. And my recent story is my sister, who went in for a very prolonged hospitalization for a perforated colon. She's a highly educated nurse. And she left her hospital so incapacitated, and she went home and had a terrible, terrible time. And so, you know, even in the patients who should be best capable of taking care of themselves can be ill prepared to go home. And I think that, you know, going in and making sure the patient is aware, they're not over medicated, they're not on heavy pain meds, that they can interact and absorb the information and share accurate information with you is really critical. And it can change from day to day, as you know. So I always, whenever I walk into a patient's room the next day, try to assess their cognitive ability, whether they've just been given pain meds or something that might alter their cognition. So then you go in and you can sit down with the patient and say, this is the list of medications that we have for you. Can we go through, and were you taking these at home, and is this the dose? And hopefully the patient will be able to work with you and reconciling the outpatient med list. And then resolve the discrepancies, identify what medicines the patient should and should not be taking. And then if your inpatient unit has access to the outpatient EMR, you can use that as a cross balance. And then once it's finalized, you enter the medicines into the workstation, which will be presented to you later this afternoon. But that's how you start to populate your after hospital care plan. So once you get a med list that you feel good about, then you should put it in the computer, because, you know, eventually that becomes a permanent record. Identify problems the patient might have in just getting their medicines. So, you know, once as the discharge medication list starts to become real and to be finalized, you want to make sure that the patient's going to be able to actually get them, because it's nothing more discouraging than to have a patient come back because they couldn't get the medicine, it wasn't on their formulary, they couldn't make it to the pharmacy. Any number of very commonly encountered problems why patients don't access their medicine. And then you can start to brainstorm with them. Is there any reason why you might not be able to get these medications today when you get discharged, or tomorrow when you're discharged? Or what will you do if you have a delay in, getting your medications? Or can you think of any reason why you might not be able to get these medicines? And one of the things you'll find out as you have this conversation is it's a good opportunity to explore patients' use of complementary and alternative therapies, especially herbs and supplements, because we know, particularly on Coumadin, some of these can really cause toxicity, liver toxicity. They can cause Coumadin toxicity, and patients are much more committed to them than they are to the Coumadin or the statins. And I saw a young gentleman, 41 years old, have a stroke because one of his supplements caused him to have, not because he was on Coumadin, but because it caused liver toxicity. And so this is a really good place if you're and I would use universal precautions. I wouldn't exclude anybody in the conversation of, do you take vitamins, any types of herbs or supplements, and see if you can identify any interactions. And if you don't think there's an interaction, I would still ask your clinical team if they think there might be any concern for an interaction, or to precaution the patient not to use them. Sometimes I'll negotiate with a patient, do you think you could stop taking your supplement for 2 weeks till you see your outpatient doctor? And sometimes they say no. So it's important to know, because this is a high risk situation when people are taking things other than the prescribed list, but you haven't asked about it, so they don't really come out and talk to you about it. Some patients don't have access to a pharmacy, or they may be far from their regular pharmacy. So having a list of pharmacies in the area that can deliver. And if it's unable to find a way to obtain prescriptions, collaborate with case managers or social workers. Some patients don't have benefits. You may not have that issue with VA benefits, but in our setting, some patients have issues with insurance that will prohibit them from being able to obtain their medicines because of high copay status or things like that. So Gloria is somebody you're going to know. This is going to be so common to you.
This is not Gloria Martinez. just.
How about Angie? 61-year-old lady admitted to the hospital with cellulitis. Not a big deal, right? She has a history of hypertension. She takes Zestril at home. While she's in the hospital, she's given antibiotics. She was noted to have high blood pressure, and her blood pressure medicine was changed. Her dose was changed. And she had a good response. On the day of discharge, she got an antibiotic prescription, Motrin, and a new prescription for lisinopril with a new dose. She went home, she got her prescriptions, she took them as instructed, but she also continued to take her old dose of the Zestril. This is so common, right? I mean, this is like a no-brainer. But this is why I'm saying, again, it's not rocket science. It's just, what are we going to do about it? I mean, I had a guy, the same thing happened with a beta blocker, and he came in all dizzy, and, it was because he wasn't just taking, the dose I had increased 3 days ago, but he was also taking the other bottle and, taking it all together, and it was bradycardic. So, and I don't know how to solve this problem except to have, somebody go into the house and, take out all the old medicine bottles, right? Because if you go into pretty much any patient, but especially older patients' medicine cabinet, you are going to find an array of medicines that would shock you, and stuff that probably has dates on it from 2001, 2002, that, well, you never know when you might need it, right? You never know when you might need it. And a lot of elderly people are frugal, and so they'll save them. And, next thing you know, patients are making decisions for themselves every day, all the time. The more prepared they are to help make those decisions, the less likely they are to be hurt by those decisions, or more likely to actually consult and get help before they act on those decisions.
Can I ask a question?
Yes.
What have you done to help alleviate that problem? Is there a best practice or?
Well, the best thing that we do at discharge is to give them those 3 questions. What's wrong with me? What do I need to do? And what do I do if something goes wrong? And again, part of that is, why do I need to do this? And having the understanding of why I'm taking this medicine, why it's important for me to keep taking this diuretic. I had a gentleman stop taking his diuretic because it made him have to urinate all the time, and he couldn't leave his job where he was at someplace like a factory or someplace where he had to stand in the same place all the time. Just stop taking the diuretic. So helping them know why they're taking what they're taking and why it's important to continue, and what to do if they have a side effect or a problem before they act. So I always ask them, if this isn't working for you, please call me and tell me before you stop taking it so that we can do something about it. Now, if you say that, you have to be available when they have a problem. And if you're in a situation where that might not be happening, because I work with 2 nurse practitioners who are every day in the SNF where I work. So if there's a problem, they're available. But if you are in a situation where there isn't somebody to contact and get advice from when they're having a problem, then it sets them up, right? If to make a decision on their own, without any advice.
So when you've done the med rec and you have that printout, the discharge med list that's color coded, have you found that to reduce the problems of them taking old meds at home or whatever? Because I know we have a lot of patients, some of our patients do have to make copays, and they'll keep old meds, because in case they end up going back on that medicine.
Right. So
have you found that list, that accurate list, to increase adherence to the actual?
Well, just like Gloria, what happens is they are adherent to the list, but then they don't necessarily know that they're not supposed to take what they were already on. So if your list doesn't have lisinopril on it, for example, they may go home and keep taking the lisinopril because even though that's not on their list, it was what they were on before, and maybe you just forgot. So did you want to say something, Jess?
Would the software allow you to say these are discontinued medications?
We looked into that because it was a concern. Even if you do the teaching of you are not supposed to take this anymore, but it became more of a teach back issue, because if you put it on the after hospital care plan, am I supposed to be taking that or am I not? So it was part of a focus group, and they decided to not put the discontinued meds on the after hospital care plan. But in addition to the teaching about what medications you're stopping and doing the teach back, this is also something that's caught on the follow-up phone call, where the pharmacist says, go and get every single medication you are currently taking and bring it to the phone, which goes back to the question of how long that phone call takes, can be pretty variable. But I think that was one of the things she caught most often with someone. And also for the discharge educator, because you're having so many conversations with the patient about medications, they'll say, well, I'm not going to take that because I know my insurance company doesn't cover it. So, going back to the team and having them write a different medication can kind of prevent some of those issues too. But a lot of it is the teach back and the follow-up phone call, which will hopefully catch these.
We know that the patients who complete the phone call have much fewer readmissions and adverse events. So something good is happening in the phone call, and because it's happening in such a short period of time after discharge, there's not that much time for bad things to happen if the patient is not on the right medication regimen. So reconcile the discharge plan with national guidelines. We've kind of talked about that. There's a checklist. And again, I think the biggest thing that a discharge educator might encounter is some resistance to being, to questioning the team. The team may feel, like not welcome that checks and balances, but I think a good high-performing team would and should. And so discharge educators should be encouraged to make those inquiries if they see that the discharge plan doesn't completely match recommended guidelines. And like we said before, a lot of times there's a reason for it, but sometimes there's not, and it's just an oversight. And it's a good opportunity to avoid an adverse event. So teaching the content of the discharge plan and teaching the patient about his or her diagnosis. So before finalizing and teaching the discharge plan, ask about health beliefs. So does anybody talk to patients about their health beliefs? And what's your experience with doing that? What's it like?
No potato chips.
Oh. Here, you want to use my antenna?
Actually, I always ask that when I was doing home care and when I had my own private practice, I would ask my patients how they viewed their own health and what context. I didn't use those words, and they were actually very open to talking about what their ideas were on their own health, and that informed me on how I needed to teach them. It helped me assess what they knew about their illness, what they knew about their medications.
Yeah. Yeah. Any other experiences talking about health beliefs with patients? For some reason, clinicians don't always feel comfortable, or they don't feel like they're going to get much relevant information. But if you work in this state, particularly with very diverse populations, you're going to find everything that's most of which is not in the medical context of how diseases operate. My mother is a nurse. She comes up with the best stuff I've ever heard about why she doesn't need to do this or why that's happening. My baby was born with an umbilical hernia and she wanted me to put a quarter on it. And, she was like a very highly skilled labor and delivery nurse for a long time. It's not hard to ask people. And the thing is that if what you prescribe for them as a discharge plan clashes with their beliefs about their health, they will go home and do something different. And, I had this situation where with a pediatric patient, but this could have been with anybody. And this kid had asthma and was coming in all the time to the emergency room. And I had never met him before, but I knew he had come in 4 other times in the last month or so, and I pulled up his shirt to listen to him, and I saw all these dark, round spots, and of course you're going to know what I saw. What? Cupping. Oh, but I didn't know that, and so I was like, bad mother. And, I made a fool of myself in about 30 seconds flat. And I ended up having to apologize because I called the social worker. And because I thought, she's beating him and that's why he's here all the time. And she doesn't give him his medicine. And oh, God, I went to town. And luckily, I was only an intern and I've learned a lot since then. But the point is that she was an Oriental medicine doctor. She, practiced Oriental medicine. And her understanding of asthma was an immune deficiency. So why would she go and give her kid prednisone? Because she knew very well how it worked, and she had reservations about it. And after I humbled myself and asked apologized for embarrassing her and myself, I said, if this is your belief system, why do you come here? And she said, I'm open to helping my son any way I can. And so I realized that it's not a clash; it's just a negotiation. And we shared ideas, and I got to understand what she thought was going to help her son, and we shared a really good conversation that lasted the rest of my career. And I think that that's what's important is it's real patients. I can't say this enough. Patients go home and make decisions for themselves all the time. And I underestimated the power of a health belief system and how quickly patients will act on that system. And in getting to the family unit, I mean, so many times the family are the first line responders in any illness, and they are the consultants. So if, the family is not in agreement with the discharge plan or the treatment plan, sometimes the patient will abandon it once they are discharged from the hospital. So it's worthwhile to have this conversation, for somebody to have the conversation of what do you think is causing your symptoms? What are you most worried about? What do you think will make you better? And letting them know that you want to know will help them feel comfortable disclosing that information. Anybody want to share some health belief stories? No good ones like I did, embarrassing myself. Okay.
I think you should have talked to your mother. She would have told you about the cupping. Next time, get a nurse involved, will ya?
My mother and my sister are both nurses, yes. They've taught me more than any attending I ever had. Okay, so, and also interpreting results. The discharge educator can help interpret the results. So a lot of times teams of clinicians come in, they sit around the edge of the bed, they tower over the patient. The patient can't hear anything in that intimidating environment. Sometimes a discharge educator who has the time to sit and give time and listen and can help explain and interpret things for the patient so that they leave with a better understanding of what's happened to them. Medications, again, it's so important to spend enough time talking about the medications and using the discharge after hospital care plan to teach the medicines is going to be very helpful in encouraging the patient to use that after hospital care plan to refer to. And some of the things that you really want to cover, and I really encourage you to prioritize this, any changes to medication, as we've already talked about, changes in doses, correct doses, what's the right dose to take, the time of day to take the medication. So using the chart, using the calendar to help identify when they'll take it, and using symbols for patients who need symbols. The reason that they're taking it, patients will say, I don't know why I'm taking this, and it's costing me $50 a month. I don't feel any better. And, my mother did that. Next thing I knew, she's walking around. She had stopped her diuretic, had no idea why she was taking it, figured she didn't need it. And it made her pee all day, so why bother? Why are you taking reasons that you're taking it? Importance of bringing your medicines to your follow-up appointment. Some of this is, we take it for granted, but it needs to be explicit for patients. And patients, if they're given information in a way they can digest, can be very, very committed to following their plans. Being clear about which medicines to continue and which to discontinue, how long to take it, potential side effects. Again, this is the conversation about what to do if something happens. You might tell somebody, you might feel tired for the first week when you start this medication. That's okay. It's very common, right? Or you might have some loose stools when you take this antibiotic. That's okay as long as it's not 5 or 6 times a day or associated with pain or fever. Letting them know that potential side effects, may occur will help patients feel more comfortable adhering through minor side effects. And then not to discontinue without consulting. I really try to emphasize that because that way, at least if they're going to do something like stop a medicine, somebody knows about it. And it's not, you don't find out after they've already come back to the hospital. Did you want to make a comment?
Ask a quick question. At your hospital, did you set some kind of cutoff time prior to discharge, after which time the physicians couldn't be changing the discharge meds? Because I think everybody's had this experience. You want to do the teaching, but it gets crammed into the last 2 minutes because the med list is changing up until the guy's walking out the door.
Well, and that's like like Brian's dad, right? They just decided you need to be bridged, so here, go watch the DVD and have a good time. And I think that's, no, we don't have a limit. Though we've operated in the real world, so things could be changed up until the last minute, and that's why you need to have the flexibility of technology to be able to adjust your after hospital care plan. And, your discharge summary isn't done, up to 24 hours after the patient leaves.
I'm glad you mentioned that, though. It is something that the inpatient physicians, Dr. Posley, has been working on, trying to solidify that much earlier so that the changes at the end are minimal. No potato chips. No lunch.
Oh, he's tough.
Good thing I don't have any clothes to change into. I can't go anywhere. I think one of the things that we did was kind of in this cultural change is training the clinicians, and I hear the discharge advocates say 10 times a day, like, we need about an hour, and we just kind of round up. We need about an hour to do this teaching, so the sooner you can get that medication list done, and kind of prompting them to start thinking about it and what are they going to do here, and, kind of pushing back their timeline so that they're not waiting into the last minute. So one of the important things, in addition to seeing the patient every single day, is checking in with the team every single day and kind of bringing up those questions of, have you decided this and have you decided that? And saying, I'm going to need about an hour, before the patient walks out the door. So let me know as soon as that's done.
I think that also
made changes up into the last very second.
I think that also points to the need for a team-oriented approach and mentality. If the discharge educator is seen as somebody outside the team, it's going to be a lot more difficult for you to interact with them, even though you're acting on behalf of the patient. If you can create a culture where people are operating in a team and they see this, the need for this, that to be done in a timely manner and not changed at the last minute, I think that will be less of an issue.
I have to say, it's so exciting. If you look at this table of case management over here, boy, their wheels are spinning as they're listening.
So I had a question about your after hospital care plan you showed us.
Yeah.
And it has the medications listed, it has a name and the dose listed right underneath. And then in the next column it says take 1 pill or take 2 pills.
Yeah.
Have you ever run into, I don't know if this would happen, they take their prescription to the pharmacist, CVS pharmacy, and the pharmacy gives them an 80 milligram tab instead of a 40 milligram tab. So they fill it and now in their care plan it says take 2 pills when really they should be taking 1 now?
You mean, you want to answer that?
Exactly. So I was just saying, okay, everyone hear me. We work with a number of sites. The VA is a unique place because generally the pill form that you order is what's filled, whereas in many sites across the country it's actually not that way. In certain cases, what we've done is we've actually left the number of pills off of the after-hospital care plan. Marcus is going to show you how we make all that after lunch. But we'll actually, in the phone call, we will actually write in with the patient how many pills to take. So it's a little bit easier, a little bit more straightforward. But this is a real problem that we see every day in the real world. So.
It seems a little dangerous.
I noticed you said that you encourage the patient to bring the pills, all the pills, to their primary care appointment. Who reviews those pills?
At the primary care appointment?
Yeah. Can it be non-licensed people?
That's a good question. My personal practice is to look at all the pill bottles myself. I know other people like Christine Sinsky would have her nurse do it, because they work in teamlets, and she would have her nurse team partner do something like go through the medication bottles. The question about whether or not someone without clinical background can do these things has been raised many times. And, our experience in our venue, we felt that this person needed some clinical experience to do it effectively. Otherwise, it was a check-in, but no intervention was possible, right? So if you call up at the 3-day phone call and you don't have any clinical expertise, you might be able to identify a problem, but you can't do anything about that problem. Whereas a pharmacist might be able to intervene, give advice, help resolve the issue. So I think in the primary care office, which, we in Project Red didn't really look into the operations in the primary care office, but the question of who could do that pharmacy phone call, it really depends on the goal of the organization and what you want to accomplish in that call. If you want problems to be solved, you should have a person who has the expertise to solve the problem.
I've got one comment and one question. My comment is about the pills, and we end up with a lot of pill splitting. And so, if somebody's on 40 milligrams of simvastatin, because their meds get mailed out typically from a common pharmacy in Tennessee, they'll get an 80 milligram tablet and be told to split it. And so,
and then they won't. And then
a lot of them, patients come in and say, well, when I split it, half of it disintegrates or it bounces across the floor and the dog eats. Yeah. But my question was, because this, the discharge plan is a teaching tool, when in the process is that printed out?
It's at its point of discharge, right?
It's at the very last, when it's all finalized, that's when it's gone over.
At the last possible moment, it's done. To my knowledge, those instructions in our place at BMC, the number of pills is always in the after hospital care plan. That's not left blank. And, if there's any change to, the instruction, like if it says 1 pill, I think I'm not sure how the pharmacy could send them 80 and say, because the prescription says 1 pill. You'd effectively be changing the prescription.
They do it all the time.
Yeah, I know. Which is another reason why we have so many drug events. And so hopefully if you had a 2 or 3 day call, the patient would tell you that. Lots of patients can't split because they can't see the pill. The pill's small and they can't see well enough to split it accurately. So it's just a dicey situation all the way around.
I just wanted to go back to the question of who can complete the follow-up phone call. And one of the, privileges of being part of the randomized control trials, we did have a research assistant and who had a lot more flexibility in her schedule than the pharmacist did. So if the pharmacist tried and was unable to get in touch with the person, we would have the research assistant keep trying at maybe odd hours or something like that. And she would go through an abbreviated follow-up phone call with the patient. And depending on who this person is, they can still go through the medication list. And if there are any differences, any questions, she would bump it up to a clinician. So we can still catch those problems. But it's an issue of staffing and also, the availability of that person.
Yeah, I was having some thoughts about social work scope of practice in doing some of this role.
Yeah.
I mean, a lot of these things we do fundamentally, teach back fundamentally.
Yeah.
But I can see it being difficult to have a social worker in that DCE role on some elements, and even doing the callbacks. I mean, we could do as this assistant does. And I guess that's back to your point of, well, the facility would have to make a determination of what is the role, how far
Right.
they want to take it. I've been also keeping track of how many times you mentioned how much time you spend. And so far I don't have too many points, just an hour and a half. But I was wondering if at any point today we're going to hear about what a DCE's caseload is. How many discharges do you have in a day, a week?
Yeah. Well, so, all right, when Project Red, the DA spent about 42 minutes, ranging from 30 to 60 minutes, depending on the patient's level of illness and complications, with direct patient education. And you can imagine patients can't handle that much at any given time, right? I mean, they can't take too much new information at any given time. So 42 minutes over the course of a hospitalization can be a lot. And then coordinating care, interacting with the clinical team was about 90 minutes per subject. So over the course of the hospitalization. In the research project, they followed about 14 patients a week, or about 20 hours a week. So we estimated, that would be the workload for a half-time, 20-hour a week discharge educator. But as we talked about in another project, Complex Care, it was a different workload. They were seeing 6 patients a day. They were discharging 6 and seeing 14 a day. Yeah.
I do want to say one thing, and that it is that when you look at we've talked about this during our art collaborative and within just my own nursing leadership. An hour sounds like a lot of time. And so we are just looking at, as we look forward, please don't let that sound like a barrier for you, an hour of discharge education, because where does that hour save you in the long run? Additionally, having nurses work to the top of their license, maybe there's things that they won't be doing so that they can be doing what's critical for their practice, which is patient education.
And also, I'll say, as you conceive ways of implementing these 11 elements, there's a team process that can, distribute some of the responsibility. Conceivably, that's not how we did it, but, in a team, there is a designation of roles and responsibilities, and I think it's conceivable that, these 11 components could be distributed among a clinical team. And again, I will say it again, that the discharge educator shouldn't be seen as somebody outside of the team, because it'll make that job really difficult if the clinical team sees this educator as a pain, or somebody, oh, there she is again, and as opposed to an asset and a resource.
We have one more question, and then because it's getting close here.
I was going to ask, I don't know who it was. I was going to ask, did you involve the pharmacy consultant with the discharge? Because there's a lot of medication prior to going home, not the follow-up phone call. So there was no pharmacy involved?
Nope. Not until the 3-day phone call. Yeah. Yep. So I wanted to go on because we have a little clip of the teach back method, and we want to get to that before we run out of time. So teaching the content of the discharge summary, we've talked a lot already about what's in the discharge plan, in the after hospital care plan, the appointments, the outstanding labs, the follow-up studies that are supposed to be done on an outpatient basis, and of course the medications. And, our main mantra for teaching this plan is to use a teach back method, which is, a universal precaution to ensure understanding of this new and complex information and before the patient leaves. And so in its very most basic form, teach back is, so I've talked to you today about a lot of information. about your medications for when you go home. Can you tell me how you'll be taking your medications? And as Brian said, it's an open book test. They can use their after hospital care plan. It's good to know that they would refer to it if they couldn't remember. And so it's a little bit out of sync, huh? The video? Well, if you're interested in seeing it, we could show it at the break if you want, just so we can go through the rest of our slides. Thank you anyway. So teach back at its very basic is, can you tell me what I just taught you? Can you tell me how you're going to take your medication? Can you tell me when your appointments are, or where to find your appointment times in the after hospital care plan? And, to do that in a way that doesn't make the patient feel that you're patronizing them or testing them, because, nobody wants to take a test, especially when they're on oxycodone or they've just had a heart attack. So, you want to have that conversation. So it's my job to make sure that you're ready to go home. It would help me know that you are prepared if you could tell me back how you're going to take your medicines, what your medicines are. And you can use this after hospital care plan to help you, give that information back to me. And most patients respond well to that because it's a concern, right? I want to make sure that you're prepared. So let's find out if there's any gaps in your understanding. This is a lot of difficult, complex information, and most patients would not disagree if you said that to them. One of the things in the teach back method that you can incorporate as you're teaching the after hospital care plan is to encourage question asking by the way you interact with the patient. And so one of the ways that we do that with the discharge educators is through these patient activation kinds of strategies. So the Ask Me program and the Questions Are the Answer program are public health initiatives that were designed to make it easy for patients and to encourage them to ask questions, because patients will often feel overwhelmed and not ask questions, or feel too timid to ask questions, or feel their questions aren't important. So we can use the Ask Me 3 program, which encourages patients to know the 3 things that are most important before they leave the encounter. What's my problem? What do I need to do? Why is it important for me to do that? And we try to cover those things in the medication plan, in the after hospital care plan, and also in the conversation with the patient as we teach it. So, can you tell me back these questions? Or if can you think of 3 questions that you might want to ask your doctor, and you can put it on the patient activation page. In this way, you coach the patient to ask questions. And I think as they start to ask questions, they start to think of more questions. It's getting started with addressing gaps in understanding that's probably the most difficult. So as we teach the after hospital care plan through the teach back method, we can also help patients learn to ask questions. Teaching them about the diagnosis. We use the illustrations in the after hospital care plan that we showed earlier was an example of congestive heart failure. Using illustrations kind of helps people, but it can also be misinterpreted, especially for patients from different cultures. Some people this is high, some people this is bi, some people this is come, some people this is bi. Same thing for symptoms. Some things we think are universal, but it may not be interpreted the same way to all patients. I remember a woman, she's from Venezuela, she's a physician, and she had a baby in the United States, and she saw all these signs for the Back to Sleep campaign, which is for SIDS, right? Put your baby to sleep on his back. Well, she thought it meant, oh, put your baby back to bed all the time. They must need more sleep. And so she just kept putting her baby back to bed because she thought that, oh, these American doctors, they know they're so good and I want my baby to be healthy. So she kept putting her baby back to sleep. And then she realized that back to sleep meant sleeping actually on your back. So some public health campaigns are misinterpreted by people. And so making sure that you review those diagnosis pages, they have information on them that tells them about the diagnosis and what to do in the event of a problem and what to do to take care of themselves. Telling the patient why it's important to understand the diagnosis and why they're doing what they're doing is very helpful. And these are just a couple of quotes from our study subjects. It allows you to talk with your family and friends who might be able to help you if they have a better idea of your condition. And it can help you better understand why it's important to take your medicine and keep your appointments. And again, referring generally to the after hospital care plan. But if they don't know why they were in the hospital and what their diagnosis is, it's going to be hard for them to engage. Assessing understanding, as we talked about the teach-back method, an evidence-based communication strategy. And I think you'll be hearing a lot more about it, but in its most basic form, it's basically asking in a non-intimidating way, not testing, not pop quiz way. You know, I want to make sure that you're ready to go home. I want to know if you have questions. Can you help me know your understanding of your medications and your appointments? Teach back is a way to confirm that you can explain the information and it's not a test. And here's our video. And if you're interested, we can show it to you at the break. Okay, and you've already heard about this case. What if my patient can't understand the discharge plan? So this is not uncommon, right? We might get into a situation where there's a patient who just can't demonstrate a solid understanding of what their discharge instructions are. Sometimes if you do the teach back, sometimes either if you just repeat it and that doesn't work, sometimes rewording it, rewording the information or asking more questions about what they don't understand might help you deliver the teaching in a way that's better comprehended. If that's not working, then you might have to bring in help. You might have to call for help. So that means bringing in family members who weren't anticipated as being necessary. You may have to rethink the discharge plan. My sister, when she was discharged after 3.5 weeks in the hospital, she had a perforated colon. She was just discharged to home with my poor brother-in-law. And these are highly educated, health literate patients. They had to call the VNA emergently so that somebody could come and provide home care. So nobody bothered they didn't send any supplies home. They didn't bother to see whether she was on so much pain medicine when she left. She couldn't even take care of herself. So nobody checked to see. They just assumed that she knew what to do. And these are not people, who have low literacy or language barriers. So using universal precautions is wise. And when needed, it's best to bring in extra caregivers if that's necessary. Reviewing what to do if a problem arises. Some of the language that we teach, let's talk about what to do if you think you're feeling worse. What should you do if you're not sure you can get your medicine? I just want to make sure that you know what to do if anything happens. So you don't want to alarm your patient, especially as you talk about side effects or potential side effects of medication or recurrence of symptoms, but you want to make sure that they're aware of what to do. And reviewing potential problems, new medication side effects, difficulties getting medicines, and if they start to have clinical symptoms. Transmitting the discharge to the outpatient provider. So that usually happens in 24 hours. The discharge summary is often not ready, and that's a potential barrier that we've talked about a lot already. And it's up to figure out how your system will be able to work. The after hospital care plan will be ready, and that can be shared with an ambulatory provider if it came down to that. And then the telephone reinforcement call. So letting the patient know that the telephone reinforcement call will be coming in 2 to 3 days helps them know that to expect the call. We sometimes try to schedule them. Sometimes it works and sometimes it doesn't. But those patients who can make contact actually have better outcomes. If the patient speaks a language that the follow-up phone caller doesn't speak, you have to make sure that you have some way of providing interpreter services by telephone, if that's possible, or to have a bilingual provider do the phone call for you. Our last slide, delivering read to diverse populations. I think, anybody who works in a diverse community knows all of the encounters that you can have with patients and with various levels of language needs and cultural, potential cultural barriers. Our basic, rules of thumb are to use interpreters as much as you can whenever you need it, and to use professionally trained interpreters rather than family members, to get trained in using interpreters so that you use them effectively. Sometimes I use an interpreter, I think I can speak the language better than them. Make sure that the interpreter is qualified. Family members often are not good interpreters. Inquire again about the use of alternative medications or practitioners, and discussing upcoming holidays. I think this is really important, and one of the things you can do with the calendar, because we had a calendar that showed the appointments, is you could populate that calendar with commonly observed holidays and then show it to the patient and say, do you plan to observe any of these holidays? That, especially if you have patients with diabetes or other comorbidities where the holiday may result in a dietary change or a disruption to regular medications. Where there's fasting involved or other types of things. So showing them a holiday a calendar where there's holidays listed may help prompt them to say, oh, yes, we're going to have this observance, or yes, I'll be eating salty food that day. So trying to make sure that you've addressed those issues and arranging for language services where possible for the outpatient follow-up. Again, identifying the role of family members in the patient's treatment. Typical treatment plan. Again, sometimes family members can be, they can really limit the effectiveness of your plan if they feel that your plan doesn't concord with their health beliefs. So it's really good to understand that there's not going to be that barrier. And if you find out there is, it's good to go back to the team and tell them there's going to be a problem with this health plan or with this discharge plan. And then also in certain clinical situations, the family would not want the patient to be informed about their diagnosis. As the discharge educator, it's always good to check in with the clinical team to see if any of that stuff is going on, because you don't want to be the one that walks in the room and tells a patient about a life-limiting diagnosis that could create a huge tidal wave of cultural distress. So, make sure that you're in communication with the rest of the clinical team so that you don't find yourself in that type of situation of disclosing information either the patient's not aware of or the family isn't comfortable sharing yet with the patient. And then if you have the possibility of creating the after-hospital care plan in the patient's preferred language, that's always preferable, and then using the color-coded calendar to identify important dates. Okay, I think we can stop.
Okay, great.
Yeah. Sorry.
I hear the bellies growling of all these hungry professionals. I just want to let you know there are like 6 different gourmet salads. I'm going to be at the end of the line, so save me a little of each.